one of the gratifying things about aging, or at least to be an aging academic, is to see young people come in for training and then come out of training and become who they're going to be, launch themselves and do amazing things. And there's no more brilliant example of that than what Kelly has done to generate so much interest, really launch a field, I think, and to tap into an area with so much need and opportunity. When I got to preview her talk, and so afterwards I wrote a little note to myself, and I thought I would share it. I wrote the real measure of who we are as physicians, as caregivers, is not how well we take care of the well, how effectively we support the resilient, but who and how we are with the most ill and the most vulnerable. I suppose I'm sort of stating the obvious, but it's worth restating. It is how well we persevere in the face of our own uncertainty and even anxiety to deliver the best care we can to those who need us the most. And that often means those who are least able to ask, least able to comply, and in the short run, least able to reward us for our ministrations and efforts. So I wrote that as a little note to myself that you inspired me, Kelly, and I think you've inspired us all. So I'd like to turn for further reflections on this important topic in the context that each member of our panel comes from, and to talk about how they've resonated with what they've heard today. And maybe we'll just go right to left, start with Engle Ennis, who was introduced to you earlier, Senior Vice President at MGH and a cancer doctor as well.
Oh, thank you. Thank you, Dr. Rosenbaum. And thank you, Kelly, for the invitation to be here today. What a wonderful event, and it's so amazing to see all of you in the crowd here. I am a thoracic oncologist first. I'm a lung cancer doctor, and I think that my relationship with the Psych Onc department has really transformed my ability to be able to give high quality care. I can think of so many examples that are very similar to the story that we heard from the Archibald and from Dr. Farrago and the people who are taking care of the patients on the front lines. And I think that for so many reasons, this is so important in the routine care of patients who have mental illness in our clinics. I think the other place I see this is one of my other big interests is in lung cancer screening and pulmonary nodule management. So I was fortunate enough to partner with many people, one of whom I think you'll hear from later today, Dr. Elise Park, in launching the lung cancer screening program at MGH and also our pulmonary nodule program to be able to navigate and care for patients with high-risk pulmonary nodules before they turn into cancer and hopefully treat them early. Before they're metastatic and incurable. I think in that population, we see a lot of patients with tobacco histories and other things that, and concomitant mental health issues where having reliable, good, embedded, collaborative mental health services, as well as warm, caring people with navigation roles in that population is so important to be able to get them the early care that's necessary to be able to actually cure this disease before it becomes metastatic and incurable. And lastly, I think I'm introduced with this title first all the time because it's the one with a lot of letters, but the Senior Vice President role for the Mass General and Massachusetts General Physicians Organization. I'm a Senior Vice President of Performance and Service, and I think about that often because it is not performance and service for only the patients who come from a high socioeconomic class, who are white, who are moneyed, who have commercial insurance, who have all of those things that line up. It's service and performance for all of the patients that walk through our door. So when I hear stories about the fact that Kelly needed to make a phone call to get Mr. Archibald into the surgeon's office to have a procedure that he truly needed, that he knew he needed, that makes my skin crawl, that couldn't happen without her intervention. And I think that is the kind of story that gets me up every morning and to work because, well, and they come from all patients, no matter who they are. I think one of the things that I'm most concerned about it is that at MGH specifically is that we are not a fortress set apart on a hill from our patients. One of the major initiatives that we're working on in the Massachusetts General Physicians Organization and MGH is on access. So we need structured, reliable, effective, and caring and warm communications with patients that do not push our patients away, but instead bring them into the care that's available at MGH. And we're actively working on that in a number of different ways. I think I'll stop there. I have some other comments, but I want to let the rest of the panel introduce themselves. But it's really a pleasure to be here today and to speak from my perspective on the systemic aspect of delivering care that we can improve on to improve care not just for patients who have severe mental illness, but really all patients who seek integrated care at MGH.
Thank you, Inga, and we'll come back and have more conversation. And so Emma Stanton, as introduced to you before, is Associate Chief Medical Officer at Beacon Health.
Thank you. Good afternoon, everybody. My name's Emma, and I'm a psychiatrist. And as you heard in my introduction, I'm originally from England, so I can testify this is not a uniquely American or MGH challenge we have. It is ubiquitous, sadly, across developed health systems, this siloed delivery model between people who have serious mental health problems and serious medical problems. And before I became a psychiatrist, I actually trained as a surgeon. And I distinctly remember many individuals who came in for what would otherwise be routine procedures, but because they happened to have a co-occurring either substance use disorder or serious mental illness, we were completely intimidated and clueless to know what to do with the complexity of polypharmacy that these individuals presented us with. It ended up meaning that these individuals sometimes had their what would otherwise be routine procedures delayed, their admissions would often be more than twice as long, and it was actually that experience, and I became so intrigued by trying to do a better job for these people, many of whom didn't actually improve after the procedures anyway, that I decided to become a psychiatrist. And actually my experience being on a psychiatrist on inpatient acute adult psychiatry wards is that exactly the same siloed experience happens. That in one of the stories we heard earlier, we heard how somebody came in and they checked their oxygen saturation levels and saw they were low. Now, just doing that on acute psychiatry ward is mission impossible. And we had, when I was working on an inpatient psychiatry unit, we did a really horrible job of dealing with co-occurring physical health conditions. And it wasn't because the teams I was working with, either as a surgeon or as a psychiatrist, were bad clinical teams. These are incredibly dedicated healthcare professionals that are just set up in very siloed delivery systems, totally unrepresentative of the kind of brilliant level of integration that we've heard demonstrated today that is very inspiring. So I work for an organization called Beacon Health Options. It is a payer organization. And I guess the main point I wanted to underscore is that these silos that we have in the delivery system that make doing the right thing for the person sitting in front of us so challenging are replicated not just in the delivery system, but also in how we code for these individual conditions, how we code for the procedures that are involved, and actually how we silo the funding streams that actually make it difficult to achieve the kind of integration that is in the best person, in the best interests of the people sitting in front of clinicians who are really trying to do the right thing. So I think there are innovative reimbursement models emerging. Some of the most exciting programs that we drive from a behavioral health payer perspective now recognize that you can't look at funding for behavioral health in isolation when you have so many co-occurring medical conditions. But these kind of innovative reimbursement mechanisms are unrepresentative of the majority of how healthcare funding flows. And my final call for action would be I might take two. One is, as David Ryan at the beginning called for kind of more robust research into what effective delivery models of care look like, I think that also needs to include effective funding mechanisms to make these kind of effective care models sustainable and move beyond the kind of research pilot phase into how we do things. And then my final comment would be, because we have such a diversity of organizations represented in the room this afternoon, which is fantastic, and I know it's an underrepresentation of the number of people that would have liked to have been here, but many people will be involved in the Massachusetts Accountable Care Organization's transformation that is due to go live later this year. And I think that's a real opportunity for us to think about embedding some of these best practices for people with serious mental illness who are being called out as a distinct group by Mass Health, to then also think about when those individuals have cancer and indeed other serious medical illnesses, how can we do a better job of identifying that earlier, making sure that we call that out not just clinically, but at every level of the system, including payment.
So next is Cathy Sanders, who is Medical Director and a Deputy Commissioner of Mental Health for DMH.
So I really wanted to be very grateful to be with all of you today, because this topic is really extraordinary in that it sort of addresses a lot of the issues that really are what we're trying to push and develop through what we call behavioral health integration. And what we have been looking at is that's the way to really drive down or increase access, drive down stigma, and also really address parity. As I was listening a little bit earlier today, it made me really realize that a Department of Mental Health has two functions, at least in our state it does. One is an overarching mental health authority that works through policy, regulations, and influencing of the healthcare delivery system to make sure that there's good access, that there's good treatment available for everybody. But the department doesn't deliver that treatment. And that's what I really want to emphasize is what the department does when we serve individuals is that we really provide things that insurance or the healthcare delivery system does not provide. That's a lot of the sort of support, the advocacy, the ability for people to live as independently as possible within the community while living with serious and persistent mental illness. And I'm going to emphasize some of the things that Kelly said earlier and bring it down to Massachusetts. And what we know is that in Massachusetts, statistically by SAMHSA, there's probably about 160,000 individuals living in our Commonwealth that have a serious mental illness diagnosis. The Department of Mental Health serves 22,000 of those individuals. So you know right there that there's a different challenge in who we serve are often the most in need, the most least resourced, and the most that need that support to function day to day in our communities in a safe and recovered manner. Very important. But what I wanted to do is acknowledge that Dr. Dan Breslin is here with me today, and he's one of my colleagues at DMH who oversees the deceased client profile database that we carry. That's an important thing. About 240 of our 22,000 die every year. And we keep a file on details of their life and what was happening at death. And what we have found is that, surprisingly, but I'm just bringing it home, Kelly, 62% of our population die of natural causes. But the real important fact is the average age of death in our population is 53 years old. The horrible thing is that has been the same in 1992, 2000, 2010, and 2016. Our population's the age of death has stayed constant over the past 25 years. And you know how many developments in medical care for those natural causes have been developed, managed, and utilized. So that, and also the average age at death for the average citizen of our state has gone in that same period of time from 75 to 81 years of age. So that gap has widened, and I affirm what Kelly says. We're approaching a 30-year gap in life expectancy between an average citizen and a citizen with severe and persistent mental illness. So what is that natural cause? 40% is cardiovascular, 30% is cancers, and 20% is respiratory diseases. I just think we have to really take this home. What I'm concerned about is, as a mental health authority, we are really advocating for early detection, early intervention, and chronic management, active chronic management throughout the lifespan of someone early detected. What is different than what we do with hypertension? What is so different with diabetes? What is so different with many of the chronic medical conditions? And yet, why isn't it more robust around someone with the chronic condition called severe mental illness? There is a parity issue here. And I think that the solution is going to have a lot to do with behavioral health integration driving our healthcare delivery system. And that behavioral health integration will allow medical and mental health providers to work side by side, hopefully as much as possible in teams, to really be able to embrace who the unique individuals are in the population served and early detect, screen, figure it out, address trauma, address social determinants of illness of all kinds. And that's what this hopeful experiment, hopefully the wave of the future with accountable care organizations, is really going to help get going here in Massachusetts. So I rise with you.
Our last panelist to comment is Chris Markey, who's a state legislator in the Commonwealth of Massachusetts.
Thank you very much for having me and listening, because I think it's fascinating. One of the things I've taken away in the brief time I'm here is this idea of silos is everywhere. It's in criminal justice, it's in housing court or housing, it's in the medical field, it's in the mental health field, it's in every aspect of our communities. And it's frustrating for people who are in it every day to deal with the bureaucrats. Okay, and I think that is where I hope our state government can do a better job. And one of the things that I always joke about when I come to something and people are talking about advocating for something, and they just say this regulation or this idea is getting in the way. And one of the things I've heard is HIPAA being an issue, and I know that's a federal issue, but that's a real problem. And also guardianships. I'm also a practicing lawyer, and I know the effort it is to get a guardianship and the effort that is required to do that. That, to me, is something that, again, you heard about it. It's advocating for someone who cannot advocate for themselves. Back when I was a young assistant DA, my boss used to say this to us all the time, and I heard someone mention it earlier. Dr. Rosenbaum said it earlier, that there's easy cases where you have the college-educated kid who's walking down the street and is attacked, right? He's a sympathetic victim. It's a gang that has done it, or whatever else it is. Those are the easy cases. The tougher cases is when the prostitute comes in and says she'd been raped. There's huge credibility issues. She brings in a lot of baggage. That's what, and not to speak quite frankly, that's what happens here. Is it's easy when a nice person comes in and they can understand their treatment and they understand it and they appreciate what you're doing, and they tell you that at the end when they're doing well, they love you and they thank you and they're incredibly gracious to you. It's a lot different when there's someone who doesn't appreciate what you're trying to do. It's a lot more difficult to speak with someone who's arguing with you when you're just trying to help. I have that in my own law practice. I get it. I just want to make sure one of the things that I can take away today is that we can find ways to make your job easier. I believe that our government is made to establish an infrastructure, not just roads and rail, but an infrastructure to take care of our community and give you the tools available and not increase hurdles for you to establish good rapport with your clients, your patients, and making sure that our community is better as a result of removing obstacles and making it easier for you to do your job, and have it so that at the end of the day, you can look back on a Friday afternoon and say, damn, I had a good week this week. This is what happened. I was able to help this person, this person, this person. And you know what? I didn't spend 45 hours on phone calls to insurance companies and to another bureaucrat trying to get something done to get someone into a hospital to make sure that this gets done. So I'm aware of it. I hope that after today that I'll have some ideas of what I can do to help you. But I just want to let you know that that is something that I know the speaker and I have talked about previously, is making sure that the mental health funding is there and those types of things. It's including substance abuse and making sure we focus on those real issues that are affecting so many people on a daily basis in the Commonwealth. So thank you very much for having me.
Thank you. Thank you, Chris, for your remarks. So one could be optimistic because we have a vision presented by Kelly and supported by others that means that we recognize the problem and that we have the wish or will to solve it. But make no mistake that this is an incredibly heavy lift. And if we walk out of here inspired, that's not enough. I worry because every day you pick up the paper and you see the challenges for healthcare in general, let alone mental health care and the complications of mental health and medical care together. It's a zero-sum game. And while I'm inspired by the idea of maybe behavioral health integration will be an answer, it's not the same as talking about reallocation of resources or new resources for an incredibly big problem. So I would like to turn back to the panel and look for more guidance, so people might leave here at the end of the day with some ideas about next steps. And Inga, this isn't fair, but Kelly said you're, quote, someone who knows how to get stuff done, unquote. So I would maybe if you could kick off that conversation about how we get this done, and knowing it's going to be an effort.
Sure. I think, well, I like to start by saying transformative change and transformative results comes from transformative work and significant lifts. So, you know, the way there isn't going to be easy, but I do see pockets of light and ways that we can move forward. And I think one of the first things that I've found very useful, and I see in other arenas, is that we can accomplish transformative change by engaging and empowering the front line, the people who are actually working with this population every day. So the community workers, the people who are in the mental health clinics, the people who are at our front desks in the cancer center, the MAs that room the patients. If we ask those people who should have integrated mental health care, I bet that they could accurately actually identify those people, because they spend a lot of time with those, and they see the people who are coming in with them. I see Angela, who's shaking her head, who is one of our schedulers. Angela spends more time with our patients, actually, than I think sometimes I get to. So I think that engaging frontline workers is important. The second thing I would say is standardization. It's a dirty word sometimes. There's a lot of people who buck against the word standardization. But if you are trying to achieve transformed results, transformative change in a large institution, we have to have standard methods of screening for severe mental illness and then standard responses, just like we do for many other issues. I think, and along those lines, we need to leverage technology. So one of the things we talked about as a barrier at my table is the fact that sometimes I don't even know who the community partners are, the people, the actual people who are helping to take care of the patients that we share. And I certainly don't know how to get in touch with them. Some people have work emails, some people use their Gmail account, some people shouldn't use emails, some people would prefer to be paged. And then likewise, I am in a fortress. If anyone wants to try and contact me, good luck. It's very hard. So you have to call. You'll be on hold for a long time, and then hopefully not too long. But we'll take a message, and then it'll go through layers and layers before you get to me. So I think, and we do that for a variety of reasons. However, it's not always in service of our patients. So we need to leverage better technology service to be able to, can you imagine an app where I could push the app and instantly communicate with all of the team, including all the mental health partners for a patient, get an instant, quick conversation to go over some of the changes in the treatment plan and some of the things that we're considering together, or even quickly have a quick conference call where everyone can hear the news together, and so that the partners can all be on the same page. I think that technology exists. We see that happening in many other different industries, so we should be able to leverage that technology for better communication. And then lastly, I think really substantive change comes from aligning incentives and goals together. So someone mentioned the example of having it taking a lot of time. The patients take more time than usual. So we've dealt with this in other arenas. There are other subpopulations of patients, like for instance, our international patient population and others, where we have aligned the incentives with the problem to actually solve the problem. There was, many of you probably know who Brent James is. He's a great healthcare quality thinker, works out of Intermountain Health in Utah. And he says that every system is perfectly designed to achieve exactly the results that it gets. So when we look at our results and we don't like them, we need to look at the design of the system that's creating these results over and over and over again. So I think those are some of the ways that I think about transformative change.
Wow, did I call the right number? Thank you. And we're only $100,000 away from that app. I mean, that app sounds like a brilliant idea. Is somebody working on it? Because there are a lot of skilled people who are creating apps right now for all kinds of things, and particularly even related to behavioral health. This sounds like a real need and opportunity. So keep that one in mind. Kelly, do we have time for more? It's 2:16. Okay. So I can call on someone from the panel, or I want to make sure if there are questions in the from the attendees. Anybody would like to ask a question to one of our panelists?
Anyone in the audience want to ask me a question or ask the folks up here a question before I give you guys your marching orders for what I want you guys to work on this afternoon? It's a working afternoon. Yes, Corey.
So I love everything that everyone's saying, and I wonder about the idea of flagging people with severe mental illness at the time when they need specialty care versus at the time when they need preventative care, and how could we do something about that?
If you don't mind, I respond to that. So I think it's interesting. So I think flagging, thank you. So flagging is interesting when we think about stigma as well, exactly what we're flagging. What are we flagging? Are we flagging frequent flyers? Are we flagging people with particular diagnoses? It has meaning. So I've thought about that a lot, and I try to take a step back. And what we're doing, we're trying to create a registry where we do screen and identify all people with serious mental illness so that we're aware of those people, so that the time they get a comorbid medical health condition, we would know right in that moment. And I said, it wasn't enough to know a week later. We want real time so that we can go to the hospital when they're in the hospital to try to engage them in treatment. So we're trying to work on that right now. I think that when you flag someone, I think about this with informing the very able front desk staff or the radiation oncology techs. Along with informing, I hope that there's education. And they're not always linked. And so there's a responsibility there that I try to think about. But I think in concept, it's a very good idea.
Great. Well, I want to thank the panel for really excellent remarks and appreciate all their effort. Thank you.